estaremos trabajando en grupos pequeños. A partir de ahorita, cambio a inglés. Si desean escuchar el resto, seleccionen la función de interpretación. Good afternoon. My name is Rodrigo Stein. I am the Director of Health Equity and Community Partnerships at La Clínica del Pueblo. On behalf of La Clínica del Pueblo, it is my pleasure to welcome you on behalf to our program space, Diálogos para la Acción. Before we begin, I want to thank our panelists and the audience for joining.
Agradecer a nuestros panelistas
Working behind the scenes for making this event possible, including logistics, interpretations, and everything that is required to make the virtual space a reality. We have a diverse participation in this dialogue. We have researchers, doctors, students, health promoters, social activists,
de salud, activistas sociales, administradores de
some even from Latin America. Diálogos is designed as a space that can illuminate, motivate, and engage us with alternative perspectives on the steps needed to advance health equity for immigrant communities. Our hope with this space is not to provide you with more information, but rather to develop a collaborative space for learning and exchange where we engage critically with topics and return to our places of work energized with new networks and perspectives to promote health in our communities. Today's Diálogo examines the lessons learned from the COVID-19 pandemic and how to promote vaccination efforts within the Latino immigrant community. As a federally qualified health center, La Clínica represents one of many safety net clinics across the country. As such, it is well positioned to demonstrate that reducing health inequities requires intention, coordination, and a recognition that our collective health and well-being is intimately linked to our ability to respond to those who are on the margins and systematically excluded. Often, these stories and figures are not collected within the clinic or doctor's office, but rather in the community itself. If one of the core principles of public health is assessing and monitoring population health needs, service providers should investigate what afflicts, but also what protects our community's health before they reach our doors. The speakers today in today's Diálogos will try to convey that message. Lina Guerrero, Community Partnership Specialist at La Clínica, begins by illustrating the important work FQHCs can do to collect community perspectives and barriers to inform service delivery and policy change regarding vaccines within the Latino immigrant community by presenting her findings from a white paper. We then hear from Elizabeth Andrade from Brigada Digital, who demonstrates the importance of reshaping health communications and health literacy strategies to combat health misinformation and disinformation among Latino immigrant communities. Michelle Larue follows up on why community-based from CASA, follows up on why community-based organizations should be well integrated into any large-scale response like the pandemic required, and why health departments should be more intentional in developing trust in communities and investing in those partnerships. We finally conclude with a presentation from a team from the Institute of Public Health and Innovation, IPHI, Abby Charles, India Richards, and Chaya Ortiz on the essential role promotores de salud or community health workers play in health promoting efforts, especially in the context like the US, where access to healthcare is not a right. La Clínica understands that these issues are complex, but honest conversations built around dialogue can illuminate a path forward. We hope you enjoyed today's dialogue and remind you to follow us on social media. Lina, welcome.
Hello, good afternoon. My name is Lina Guerrero. I am the Community Partnership Specialist at La Clínica del Pueblo. I'm really excited to be here today. I will be presenting about mapping barriers and enablers of COVID vaccine uptake, the role of federally qualified health centers can play in addressing health inequalities in the Latinx community. The objectives of this presentation are to highlight health inequities during the pandemic for our community, present results of a community assessment and white paper, examine barriers and enablers for vaccine uptake in Washington, D.C. and Maryland, and demonstrate the importance of access to primary care to increase vaccine rates. First of all, I would like to define what a federally qualified health center is. It is a funded community health center that provides healthcare services and health education programs to all people, regardless of their ability to pay or documentation status, on a sliding fee scale. These centers provide a safety net community for communities who are excluded from conventional care. La Clínica del Pueblo is an FQHC since 2007. La Clínica, in their community programs, has two departments. One is the Community Health Action and the other one is Health Equity departments. These two departments complement each other. The Community Health Action provides and offers direct services to clients in issues such as domestic violence, chronic diseases, and sexual prevention, and provide a navigation to resources. Health equity tries to influence systemic changes, mapping barriers, promote community partnerships, advocacy efforts, and community participation. As Rodrigo mentioned in the introduction, health equity needs to be coordinated with direct actions in the community. That's why these two strategies are very important to promote change. Let's talk about what happened during the pandemic. So definitely the rates and deaths in the DMV area have been higher in the Latinx community compared to white communities. For example, in Maryland, in Prince George's County, most COVID cases and deaths were the highest in the whole state. And the most affected neighborhoods were where Latinx community lives. In DC was not different. The Latinx residents had a mortality rate of 4.7 times greater than their white residents. So when we were during the pandemic, we tried to do something that could give us some answers to these questions. We wanted to do a community assessment that could tell us how were these inequities reflected in accessing the COVID vaccine. We also wanted to understand the reasons that facilitated or hindered vaccine uptake. And we also wanted to compare DC and Maryland, which are the jurisdictions where La Clínica del Pueblo operates. This could help us in real time to inform policy and service delivery. So what we did was we designed a survey where we asked questions related to ethnic group, gender, all the demographics, level of English, access to health insurance, barriers to vaccination, and factors that help people to get vaccinated. Data points, so the duration of the survey was 7 months. We surveyed 673 people, and our data collectors were 4 community health workers or promotores. We went to different places to gather this data: farmers markets, community centers, our health center La Clínica, social service fairs. We went during the day and during nighttime, and we collaborated with CASA and Luminous that were key partners for us to collect this data. Let me take you to the results that we found. The group of people mostly were between 25 and 64 years old. You can see here that the blue is DC and the red one is Maryland. We had people around all group ages, but mostly adults from 25 to 64. The state of residence. Most people that we surveyed were...
Estado, la mayoría de las personas a quienes entrevistamos estaban en Maryland, 73% de ellos, y 25% de ellos estaban en DC. En cuanto a los códigos postales,
Adelphia and Hyattsville in Maryland, and 70 people from DC, from Columbia Heights in DC. 120 people did not respond this question. Regarding gender, it was basically half and half of people that identify as male and female. Ethnicity, most people, 92% identify as Hispanic or Latino. And English proficiency, as you can see, this shows us that most people either say that did not speak English or they felt they were in the beginner level. Here we can see the question was, do you have health insurance? On top, we see that in the first graph, we see that only 1/3 of the respondents have health insurance. And we divided the data by DC and Maryland, and you can see the opposite responses, where in DC, almost 70% of the people have insurance versus Maryland, only 23%. Some of you might know that this is because, or this has a lot to do with the fact that DC provides a DC Alliance program that provides health insurance no matter or regardless of your immigration status. In Maryland, there is no such a thing. So that might be the reason why we got these results. The next question was, why don't you have health insurance? And the most common reasons were, as you can see, in the left are the answers that people provided. In blue, you can see Maryland, in orange, DC, and in the x-axis, you can see the percentages. So most people said, I don't meet the requirements, and again, in Maryland was higher. This is because there is no a public health insurance program for people without that do not have the immigration status required. The second reason was I don't know how to apply, and the third one, I haven't had time to apply. The other thing that we can see here in this graph is that while Maryland people talk about cost, because their option is basically private insurance, in DC, people express more factors related to having to renew the insurance, but the cost or the affordability did not came up. The next question was, why haven't you been vaccinated? And as you can see, trust or I didn't or don't trust the vaccine was the highest in both Maryland and DC. The second factor was lack of information in Spanish. And the third factor was I couldn't or I can't miss a day of work. This reflects a reality of many immigrants where they work in places that they don't get paid time off. The next question was, what helped you get vaccinated? We can see that the highest driver in Maryland was Mobile Clinic Help Me. Most people, we provided vaccines in places where such as farmers markets or places where the community go. So that was a good answer that showed that easy access is very efficient. Family motivation was the second one for both Maryland and DC. And the personal health concerns was the third reason for both Maryland and DC. So we finished all this information, and we also compared with other type of research around the country. And we know that due to historical reasons, systemic exclusion for immigrants based on their immigration status, the lack of cultural and language appropriate services, all of this has given us the result of a lack of trust or hesitancy around vaccination. In fact, one of a recent research result showed that 1 out of 3 individuals stated that they do not trust their local health department for information about COVID. And what we also know, and the research also shows, is that access to primary care is a proven public health intervention to increase vaccination rates. So individuals are more likely to trust their own doctor on issues related to vaccination compared to health authorities or governmental authorities. And in fact, a recent study also showed that increasing the number of primary care physicians in an area increase vaccination rates after controlling for other variables. Oops. So that concludes my presentation. Thank you so much. And we would like to acknowledge all the people that participated in this survey, in the white paper, and in this presentation. So thank you for your attention.
Thank you so much, Lina. And I think the valuable data that the unit was able to collect is a nice connection between our next presenter, who is Elizabeth Andrade from Brigada Digital. Because as we showed, as a research, as a investigation that Lina presented, and the figure she showed, was that misinformation was definitely a significant barrier in developing trust and accepting or being more willing to receive the vaccine. And we also saw how access points being access to primary care, but also familiar relationships and interpersonal relationships were also key to accept or not accept the vaccine. So I think, Elizabeth, your research on addressing misinformation and disinformation with Brigada Digital is key. So I leave the door open to you so you can tell us about Brigada Digital and the work that you're doing to address misinformation and disinformation.
Great, thank you. Can you all hear me?
Yes, we can
we
hear you.
Yes, okay, great. Great, and no pressure about the importance of addressing this information, no pressure at all. All righty, I'm going to go ahead and pull this up here. And I am also going to do my absolute very best to stay on time because my job is talking and teaching, and I can sometimes get very carried away. So I'm going to do my very best here to stay within the time so everyone else has time to present. So what I'm going to share with you is about a project called Brigada Digital de Salud. And we've been fortunate to be able to partner with Clínica and also pilot this model also with Mary Center, and another current partner we have is Proyecto Salud. And I'm going to tell you a little bit about the project we've started since about May 2021. It's still really in its beginning phases.
Y también está en su inicio, pero estamos tratando de abordar este tema importante que es la falta de información en español sobre
timely and appropriate, and also, overabundance of misinformation and an absolute deluge of information online. And so the goal of the Brigada Digital de Salud is to disseminate accurate, credible, science-based COVID-19 information and prevention messages in Spanish on social media. And so the idea of this model is that it's helping health promoters and health educators to transcend into the virtual space, to access audiences that they would like to connect with, not just in person, but also digitally. And there's a number of reasons for that, which I'll get to in a minute. But just to give you an overview, this project is funded by 2 small grants, and we're hoping to apply for another bigger grant and continue it. But my co-lead for this project is Dr. Lauren Abrams and Dr. Mark Edberg at GW, and some collaborators that this project would not be possible without are Ana Gonzalez, Valeria Gomez, Carla Favetto, and Christy Weiss-Sota, who are all students at George Washington University at different levels. And so as I mentioned, there are different partners. And another one I didn't mention in terms of partners are Dr. Elmer Huerta, who's the host of a long-running radio program called Consultorio Comunitario. And you're probably wondering, what on earth does radio have to do with social media? I'll get to that in just a minute. But right now, as I mentioned, we are very much in the feasibility phase of testing this out to see how it works and what kinds of changes we might be able to achieve. So why the Brigada Digital? So social media is
Elizabeth,
really becoming.
We
Yes?
don't see your slide. I mean, we see it, but not in presentation mode.
your
Oh,
slide.
that's strange. That's very strange. Sorry about that.
It's okay. I have your presentation, so I can share it if you want.
Sure. Yeah, you want to do that? That's fine. I'm not sure why it's in presentation mode. Maybe it was the settings on the template or something.
Let me see.
I'm not sure.
Can you guys see it?
Yes.
Yes.
Great. Thank you. Okay, so if you can go ahead and go to the next slide, please. And next one after that. Yeah, so,
Oh,
as
sorry.
you know, it's okay. People are using social media more and more as sources of information for everything from news to health information. Unfortunately, it's full of misinformation as well and disinformation. And it's very hard sometimes to tell the difference, and very easy to spread information, whether intentionally or unintentionally. That's not information that's not credible. COVID-19 information has throughout the pandemic been a lot less available in Spanish. There have been a number of cases where we've been searching for data or searching for things and we're like, why is that not available in Spanish? So we have to translate everything, and no wonder people aren't trusting. They can't access the safety and efficacy data, in this certain system through CDC. It's not available in Spanish. No wonder people don't trust. So there's just not enough information out there in Spanish, and not always timely either. So, Latino communities, as we know, are very connected on social media. It's a great way to try to reach people, and especially in times when we cannot be together physically due to a number of other barriers of time and scheduling, but also when we're needing to social distance, in populations who are nervous about becoming infected with COVID. When it comes to times of crisis or times of circumstances being, not the norm, right? Like we've seen throughout the pandemic, people usually go to sources of information that they already trust. And one of those sources of information are health promoters, community health educators, and the community-based organizations that they already know and trust. And so the Brigada was trying to leverage a lot of these assets of being very well connected and having a great deal of trust with health promoters and health educators, and help this group of service providers really access individuals digitally. If you can go to the next slide, please.
Elizabeth, sorry to interrupt. Just because we have interpretation, if we can just speak a bit slower, that will facilitate the work.
Sure.
Tremendous. Thank you.
Okay, sorry about that. Thanks for the reminder. So just to give you an idea of how Brigada Digital works, part of the challenge of disseminating credible, quality, science-based, up-to-date information is making sure that it's up-to-date and science-based and correct. And that's really one of the biggest challenges. And so through Brigada, we've taken that off of the plate of health educators and health promoters by working to develop content and materials within a team at GW, where we have access to experts and in public health, in medicine, and we can fact check and stay in touch with the most updated information and create content that health promoters and health educators can then disseminate to their networks, in knowing and trusting that it's good information, right? So that's the idea. Now, eventually this will maybe evolve to having and training health promoters and health educators to be part of the development process. But in the middle of the pandemic, there were people who didn't want to take that on, and I don't blame them, because that is the most important part, and most time-consuming and most difficult. And so we've trained initially 10 Brigada members across 3 organizations, and the idea is that they share and disseminate these messages widely on their network and engage with people who might have questions, people who want to have dialogue around these topics. And so this effort, initially we're targeting Latinos 18 to 64, and also putting a special emphasis on targeting parents of children under 18, because at the time when we laid this out, vaccination was not yet available for many of those audiences. And now that even that it is available, there's still a lot of work to do, targeting parents to get their children vaccinated. And young adults who throughout the pandemic had typically been less worried about getting vaccinated, but tended to also be more likely to spread in social settings or to family members. Can you go to the next slide, please? So how do we disseminate information in Spanish about COVID? We primarily through social media, Facebook, Instagram, and Twitter. And the way we do it is we post on a main Brigada Digital page, and then Brigada members share to their networks. And of course, the bigger the network, of local network people, the better. And the idea in the beginning was that these were people's already established social media networks, right? These are people they're already connected with, but that can be modified to be people that are added to their network specific for health promotion purposes, right? Health promoters can build their own network of people who they interact with regularly doing their health promotion activities, and build a network of people to stay in contact with them and always provide them up-to-date information about COVID. And also the Brigada Digital members regularly disseminate the messages to public Facebook groups that are for the DC metro area, where they have thousands of members and they're Spanish speaking. And so they're disseminating also the messaging there. So some things we've done to kind of, we're starting out and we're still kind of a small account, but we've tried a little bit, and we will more in the future, to kind of partner with larger, more established accounts, people who are well known, either as medical experts or people who are just really funny. And like this guy here, who's Puerto Rican and I think is hilarious, Baby Kel. And we, would take some of his videos and put in our own messaging, and tag him, and he, acknowledged us and all of that. And people think it's hilarious, and they, get really interested in the information, right? And so we're trying to also make it fun. And obviously through social media, the more paid advertising you have, the better, and you can reach more people and do it in a targeted way. So next slide, I'll talk about the cross-channel messaging, I believe. So we tried something a little bit different as well. In the DC metro area, when you think, of a trusted voice in terms of health for the Latino community, many people know and love Dr. Elmer Huerta, right? And so he has a radio show, Consultorio Comunitario, on Radio America, and he's had this show for decades, literally decades. And people tune in every day from 12 to 1 and listen to his show, and people can call in and ask questions about any health topic. And he was doing a lot of messaging around COVID. So what we did is we arranged a series where, I asked him, I go, are you on social media? Are people following you? And he's like, no, not really. Not for the DC metro area. And so I said, let's do these interviews with different people from different organizations like Clinica, Mary Center, pediatricians, health promoters, and let's live stream it on Brigada, and where that recording lives also, because he's such a trusted voice and people know him. And so that's kind of a cross-channel thing that we experimented with. And then what we did later is we would take excerpts from those videos, 1 minute, 3 minutes, where they would talk about a particular topic. And we could use those as little bite-sized videos that we can use and share on social media with a key targeted message, right, coming from experts. So people don't have to watch the whole 30-minute interview. And I thought it would be kind of cool for people to see what goes on behind the scenes when Dr. Huerta does his daily radio show. What does it look like? What happens? So we tried that out. Next slide, please. So how are we addressing the issue of misinformation and disinformation? So, the purpose of Brigada Digital is, to contribute to the overall content that's out there by providing information that's credible, right? But another secondary purpose is to directly address, key points, key misconceptions, to target our messaging to things that we've identified as, widespread false information, myths, things that we identified through some formative research that we did, or just, what we're seeing, right? Through other sources of information, through social media networks and through our own social networks. So, there are so many different messages that we've covered over time. We're putting out, 3 messages per week, 3 posts per week. And so, it's been a lot of content. But just generally speaking, we hit head on key misconceptions about the side effects of vaccination for adults or children. Are there really long-term effects? Does it affect fertility, alter development, or DNA? What are the ingredients of vaccines? Debunking these myths that the mRNA technology was developed too fast, or that children are not at risk for serious COVID consequences. A lot of those, and the list goes on and on and on. And so we do directly address these things through the messaging and using different tactics that will appeal to people, but also simplify the science about how we know this is not the case, educating people on the science of, public health and what does it mean to look at a population level versus a story of one individual who had a bad reaction to the vaccine. How do we make decisions, and what information should we use? Next slide, please. So some strategies that we've used to counter misinformation is providing, the actual scientific studies or data, laying it out. And so this science is something that is accessible to individuals of diverse educational, attainment and background, and making it, speaking human, not in jargon or with complex terminology. And also transparent communications, not just showing one side of things, and helping to summarize, really lengthy articles or other things that, we distill it down to, what is the major takeaway? Using trusted information sources. So these interviews with our health educators, things from public health or medical experts, and also modeling the decision-making logic, talking through with people how we came to a certain decision, or modeling the behaviors themselves, helping people to understand how to navigate the information environment. And this is one I'd like to do more on moving forward. But if I'm surfing the internet or looking on social media, how do I know if this is credible information or not? What do I do to distinguish credible and non-credible information? And then also just making sure that our information is thoroughly fact-checked, updated. If it's not correct, it doesn't go out, or if we're unsure, it doesn't go out. So next slide, please. So we have there's a request that we discuss a little bit about, what are we finding, right? So I really wanted to share the Brigada model the best I could, to explain what it is we're doing, because it's kind of new and we're still testing it out. But we are also having ongoing studies. So one study is part of the NIH-funded Community Engagement Alliance to address COVID disparities. And so that's one study. And then another one is through GW with foundation funding, and it's they're both contributing to and assessing different elements of Brigada. So the first one, we have, it's DC specific area samples, specifically actually Maryland. And we have repeated surveys, and we are disseminating messaging in 3 channels, one through Brigada Digital on social media, one through the radio show audience of Dr. Elmer Huerta, And then another channel is through local church partnerships and reaching faith communities and helping to get good information out there, right? The 1 month randomized controlled trial is all Brigada, and it's looking at, it builds Facebook groups specifically with parents of children under the age of 18, children or adolescents. And this sample is, we recruited nationwide, and we have, I'll explain more about this. So one is kind of a nationally drawn sample, a small sample, and then another one is Maryland specific. And so I will talk a little bit about, as I mentioned, we're evaluating different things, but we haven't quite gotten there to having all of our pre-post data. So next slide. But I did want to share with you a few things that we have seen so far, and that I think would be relevant for this audience. So we're still processing a lot of the reach data in terms of social media analytics. I don't know if you've ever looked at this kind of data on Facebook or Instagram, but they've changed it a lot over the years. So there's a lot we're still kind of compiling and looking at. But just generally speaking, our page is kind of small, and we're building it little by little, but we've reached about almost 160,000 people through the Brigada Facebook page, and about 35,000 through Instagram. We have about 282 followers on Facebook, 393 on Instagram, and also we're on Twitter. So the reason why I share this is just to show you that Facebook and Instagram have been like the main sources where we're finding our audience, and where we're getting the most traction. And of course, as we move beyond the feasibility stage, we're going to look to grow this more. But right now we're kind of testing it out and seeing how it all works. Next slide, please. So in terms of outcomes, I put together, pulled some of the survey results that were most recently taken, and just in the past couple months from, it says DC area sample, but it's actually the survey specific to Maryland, Montgomery, PG County, Maryland area. But I think some of the surveys could be from DC. We were less focused on the specifics of that. They are eligible if they're DC or Maryland, but I think there's a lot in Maryland. So, and I wanted to put it up side by side, the national sample. I was just curious to see what it looked like. And they were both collected within the past 2 months, just to see what was happening. So in terms of trusted information sources, both the Maryland sample and the national sample, still their doctor or healthcare provider and the CDC were the most trusted sources of information, right? And of course, you can see that, least trusted sources are, well, there's a few of them, but I was comparing the Maryland with the national sample, and overall, the Maryland sample was less trusting overall of these information sources. I thought that was interesting, and I don't know if, the samples are a little bit different. The second sample is more parents. The first sample is more kind of any adults 18 to 64. But I thought that there were a lot of trends where they seemed to match in terms of the most trusted sources. And some of this does kind of mirror what our colleague Lina was talking about lower rates than you would expect of trust in local and state government, right? Only a third of participants trusted those sources a lot, which I think is kind of surprising a little bit maybe. And it's not much different for the US government either. And so really it's, CDC and healthcare providers. The top sample, we had a lot of recruitment from churches. So that's why you see the strong trust in faith leader. That's why you see that difference. Next slide. So I just thought that it was
Elizabeth, sorry to interrupt.
Yeah.
You have your 5 minutes. 5 minutes.
Yep. Okay. Yeah, or less. I'll go through fast. So, so what I wanted to point out from the vaccination self-report is really just that we're really, really lagging behind in the Maryland data for boosting, right? And I think all of you have seen this, working at Clinica, the vaccination rate, and this is just self-report, might be okay, but the boosting rate is a lot lower. And something I wanted to share at the national level, but we did not collect this data for Maryland, is while 83% of our participants in the national sample were vaccinated, there was a much, much lower rate of their children who were vaccinated, right? Almost half of the sample for some of these age groups were unsure or had no plans to vaccinate their youngest children. So there's a lot of work to be done. And I imagine if we collected that data for the DC metro area, it would be relatively similar. So next slide. This one actually also gets at these reasons why they haven't vaccinated for adults or reasons why they wouldn't vaccinate their children. And this was when, anyway, so I just thought it was interesting that Maryland DC sample and the national sample, the reasons were really similar, right? Mainly the concerns are around, mistrust. They're not sure if the vaccine is safe and effective, and side effects was a really big factor. And we see this in the online intervention as well. And this misconception that the vaccine was developed too quickly. So some of these key, perceptions are still really big barriers to vaccination. And I don't show data about reported barriers to vaccination, but these far surpass barriers in terms of importance than the more structural barriers of I can't afford it, or I don't have access, or I don't know where to get it. Some people saying they didn't have time or couldn't get off work, but by far these are much more prevalent in terms of barriers. Next slide. Thank you. So just to wrap up, this is really in the beginning stages. And of course, next time we talk, we'll have more evaluation data to share. We're going to be continuing the Brigada dissemination and the work funded through March of 2023, but the idea is to go big or go home, to expand this, to be bigger, to be able to train more health promoters and community health workers to work in the digital space and to extend their work into that space. And so obviously we're going to be assessing audience reactions to the post content, getting their feedback on it. What do they think of it? Preliminarily, people really like it. Our health promoters have seemed to like it. And we make our content very accessible, lots of videos, narrated if there's text, and hopefully in the next iteration, we can make this even more entertaining and more video-based. And we'll also, of course, be looking at changes in outcomes in terms of perceptions around vaccination, and particularly child vaccination, which is lagging so much behind. So that's all I have today. Thanks for listening about Brigada Digital.
Thank you so much, Elizabeth, for that valuable information. I think addressing misinformation in a saturated universe of social media and media in general will continue to be an issue that all health agencies, if they were not facing it before, is now an established challenge. However, thanks to the information, best practices, best models, we have some tangible tools and recommendations of how we can make headway and address misinformation. We can also learn how, by meeting people's immediate material needs, we can also be better suited to gain that valuable community trust, specifically for the immigrant population. And that's why I'm introducing our next presenter, Michelle Larue, of how CASA is an example of how, by providing material resources and being a trusted community voice, they were able to promote vaccination efforts, even though themselves are not a health service providers. They have health programs, but I'll let Michelle present how CASA was able to lead some of the efforts. So Michelle.
Gracias, Rodrigo. Let me share my screen real quick. So as Rodrigo was mentioning, first and foremost, thank you for the invitation to be part of this dialogue. CASA, we are not a clinic, but we felt the need to step in and help support the vaccination efforts in Maryland specifically, because Latinos were having the highest rates of infections of any race or ethnicity in the state of Maryland. So far to date, we vaccinated nearly 15,000, administered nearly 15,000 doses. And to this day, to what a lot of what Ms. Andrade was talking about, that misinformation, we are still doing some first doses, even today, as we've been vaccinating for quite some time now. We have done tailored, comprehensive wraparound strategies in supporting both our Latino and Francophone communities. CASA works trilingually as much as possible, working both in Spanish and French to really bring social services and other health programming directly to the community. And we started right off the bat as soon as the pandemic hit, supporting our communities. So despite not being a clinic, we've been running vaccine clinics in three counties across the state, which is where we have our strong footholds. In Montgomery County, at the height of the pandemic, Latinos had the highest infection rates, and we're going still further up, while other sectors of the community were actually tapering off. Latinos in Baltimore City and Baltimore County represented 12% of the infection rates, while only representing 5% of the population. In Prince George's County, which is where our headquarters is located, right there in Langley Park, 20783 for a long part of the pandemic had the highest rates of any zip code in the entire state. And we know that it is a very dense and immigrant dense community, and really was the hardest hit throughout this pandemic. So why did we decide to get into the vaccine work despite not being a clinic? Well, equity. We really saw what our community was facing. We saw a lot of large scale initiatives being instituted, like just down the street, or actually not down the street, but in Prince George's County, we had the mass vaccination site at FedEx Field. And many times this large scale logistical needs have to be balanced with making sure that equity is kept in the equation, and oftentimes it wasn't. Our community had to travel by bus, had to take a day off of work, and we know that that's a major ask for our communities, talking about hours-long commutes, hours-long waits in line, hours-long commute home, doing it on the bus or on Metro, which also further exposes our communities to the infections, as many lack their own, have to rely on public transportation. And also, you know, having to take a day off of work when our families are already in an economic fragile state, to ask them to take a day off work when you don't have the luxury of paid sick leave is a lot to ask of our communities just to be able to get vaccinated. Also, at these large vaccination sites here in Maryland, the National Guard was called into action to respond to the pandemic, and we're running the vaccine clinics. And so not only did you have to, you know, put your family's economic situation at risk, we also then had to face the trauma and the mistrust that comes with military uniforms running these vaccine clinics, really just discouraging our communities from participating. We know that a lot of large-scale pharmacy chains also was a large scale logistical means to get the vaccines to many communities across the nation. But while the vaccine was free, the administration of the vaccine is not free. And so many of these were asking for your insurance information or social security number to actually administer you the vaccines. And many times our community members lack both, lack social security or lack the health insurance to be able to get it. And many of our community members then came to us saying they were turned away. They had an appointment, but were turned away when they showed up, and were not able to actually get the vaccine. You know, many of these large vaccination installations did not have the linguistic or the cultural competency to be able to serve our communities, and they didn't have a medical home to turn to either for guidance, for questions, or for the vaccine itself. And so for all of these reasons, CASA really believed that it needed to be in this effort and really support our families in getting the vaccine, especially in the context of being those that were the highest hit with the highest infection rates with the pandemic. So what made CASA successful in doing this? Well, I think first and foremost is our long history of trust and a relationship with the community. We've been in Maryland for over 30 years. We have collectively over 130,000 members across all of the CASA footprint. We don't have offices where our community isn't at. And so location, I think was a big part of it. It obviously, it's what drives us to where we have offices, that's where our community is located. So that's where we need to be as well. And so it was very easy to be able to stand up vaccine clinics at our specific offices across our footprint. And so we've been vaccinating out of our office in Baltimore, out of our headquarters in Langley Park, and out of our offices in Montgomery County as well, a couple different offices there in Wheaton and in Silver Spring. Well, since we're not a clinic, we do have to partner with clinical providers to be able to administer the vaccines. And at times we've had to, offer translation or interpretation services to be able to still be able to provide the dignity of being able to communicate with your provider. And so when we've had to do that, we've done that, but we also have some clinical providers. And I know we have some rock star partners across the region as well, like Clinica and other community clinics that have that linguistic and cultural competency to be able to really give quality service to our members. We did end up partnering with the National Guard as well in our Montgomery County clinics. But we did let our community know, because we know that there's a history of trauma. We know that there's a history of mistrust in government. And despite that, I think, coming at it from a culturally humble approach, we were still able to be very successful with those vaccine clinics, despite having military uniformed personnel administering the vaccine. And so I can't emphasize enough the importance of knowing our community and really being able to tailor our approach to the needs of our community. One of the things that we did, we were one of the first to do it in the region, was as soon as the vaccines were open to everyone, as soon as we got rid of the phases, and it was just anyone who was interested could come, instead of going in phases by age or by need of a vaccine. We've quickly transitioned from daytime clinics to evening and weekend clinics, so that our communities didn't have to go through that struggle, really meeting them where they're at, not only geographically, but also making sure to break down as many barriers as we could. Many of our community members walk to our clinics. They come through our clinics on their way home from work. They bring the whole family. We as soon as the restrictions were alleviated, we were able to vaccinate large families all together at once, and really being able to, like I said, tailor the services to them as much as possible. And I think a big part of kind of going in hand with the first bullet, with the trust and relationship, is we were already in the mix of the COVID-19 response. We were helping our community members apply for food assistance, for rental assistance, for unemployment, those that were eligible. We've now been handing out test kits. So as the pandemic has been evolving, so has CASA's response, and really making sure to always bringing the services to the community, tailoring our responses to the needs of our community. Some of the strategies, I think, moving on forward and working closely with health departments is one, there's been so much infrastructure that has been built early on in the pandemic. We started having even daily conversations with local health departments. We partnered with the state health department to get the vaccines directly from MDH. And I really would hate to see all of this infrastructure and these partnerships just die out. I'd like to see how we can work together to be able to continue all this infrastructure that has now been created, and so far it has. And even though the pandemic, we're in a lot better state now than we were before, because our community was so hard hit. It didn't just hit our health, it hit our wallets, it hit every aspect of our lives, and the recovery of the pandemic is going to be very long and hard fought for our communities. And so making sure that our responses and our partnerships evolve with the pandemic, but also stay in longevity to be able to still continue to meet the needs of the community. The pandemic only exacerbated challenges that our community was already facing. We were already facing food insecurities and economic instability and access to care issues. And we've only seen how much that has been exacerbated throughout these years of the pandemic. So there's still going to be a lot to be responding to and supporting our communities moving forward. And now we're even seeing monkeypox. And so, there's still new emerging events or issues to be dealing with. One thing I have been seeing, and I hope this also continues, is entering into funding opportunities as partners with the health department, instead of being a sub-grantee or a minor partner, but really coming in hand to be able to tackle some of these challenges that our communities are facing. I think is going to be critically important to be seen as equal partners moving forward and solving some of these issues. And I think influential messengers, I don't want to get into promotoras, but they are, because I know we're going to talk about that next, but they are a crucial aspect to this. CASA has had a promotora team for as long as CASA has been around, and it's one of our oldest and longest running programs, and one of the most successful programs that we've had throughout the history of CASA. But they truly are influential messengers, especially with the pandemic, but also bringing in other influential messengers. Early on in the pandemic, we had Fauci, on TV every day, or state health officers or local health officers or the mayor or county executives. But these aren't always people that our community recognize. And so really making sure that the influential messengers are influential to all sectors of our communities across the board. And so really making sure, like I know Gustavo, who's our CEO and president of CASA, many times was tapped to do these messages. And it's because he's known, he's trusted by the community. And oftentimes he wanted to punt to me, and which I'm happy to jump in and also be that influential messenger. But people know Gustavo, people trust Gustavo. And so making sure that we've tailored not only the messages, but who is delivering these messages to make sure that we really are getting the results that we're looking for. And I think moving forward, we need to start to reshape healthcare and health literacy in a post-pandemic context. We have community members who already were having access to care issues way before the pandemic. The pandemic has only exacerbated it. We are seeing, 3 months, 4 months, 6-month waits for, appointments for our community members. We know that, our community clinics have been the crux of the healthcare for our community for so long. They need support to be able to meet the demand of our community. We need to reshape health insurance. We need to reshape how we look at healthcare across the board at all levels, at county levels, at state levels, and beyond. And it's really is an opportunity to piggyback off of the pandemic and really hone in on health literacy with our community, making sure that our community is understanding, their bodies, their health, in conversations with community members, whether it was a town hall or one-on-one, I really found myself speaking with community members about basic science, like talking about what are antibodies, how do vaccines work, and really I'd like to see this momentum moving forward, being able to expand this into other fields within health, and really just moving this forward. And with Prince George's County, we are running a health literacy program, and really hoping to be able to ride this wave and make connections between the pandemic and other aspects of health. We've had many families that are still dealing with long COVID symptoms, or who have developed new thinking in Spanish, sorry, new pathologies, new diagnoses since the pandemic. I was just speaking with a community member yesterday who, recovering from COVID, was newly diagnosed with diabetes. And so, being able to work with them, not only from a direct healthcare aspect, but also from a health literacy and health outreach aspect as well, and just moving the needle on our health context.
Michelle, just a 4-minute warning.
No, con eso ya, I'm all yours.
Okay.
I hand back the mic.
Excellent. Well, thank you so much, Michelle, for that perspective. And it's important to highlight how community-based organizations were key and continue to be key in any large-scale response such as the pandemic required, due to the specific trust that they garner. However, as it was outlined, they lack the resources to respond alone. As such, public agencies must continue to fund, collaborate jointly, and be willing to listen. I took that as one of the key points: listen and understand the community's material and access needs if the response is to be effective. And I think this is a good segue into our next presenter, because one way to garner and understand the community's access needs and equipping influential messengers, carrying on what we've been saying, is the role that promotores de salud can do as community health workers, and how health departments can benefit by integrating them in any public health or healthcare intervention. So with that said, I leave it to the team from IPHI, who will speak to us on the role of community health workers in vaccine uptake. So Abby, India, Chaya, the floor is yours.
Thank you so much, Rodrigo. It is our pleasure, and Chaya, India, and I get to talk about the role of community health workers, promotores de salud, in vaccine uptake. And as we move to the first slide, we were asked to speak to and to describe why community health workers are essential to gain trust in the health system. So Chaya is going to talk a little bit about how community health workers were involved in our vaccine outreach. India is going to talk about and provide examples of community health workers involved in vaccine uptake and promoting confidence. And I'll talk a little bit about some broader strategies that we can engage in to integrate community health workers at a larger scale for other health promotion activities. So we could skip the second slide because those are our objectives and move to the third one. So just a little bit about who IPHI is. We are the Public Health Institute for Washington, DC, Maryland, and Virginia. And we work to develop multi-sector partnerships and innovative ways to address public health and well-being across the region. But we see community health workers as a critical resource for addressing health inequities. At IPHI, we've been involved over the last 11 years in all aspects of community health worker workforce development, from training and employment to supporting community health worker organizing and advocacy. During COVID-19 and this pandemic, we saw an increase in interest and integration of community health workers by federal agencies, hospitals, health departments. And, IPHI, we received funding from the Health Resources Services Administration, HRSA, from the Centers for Disease Control to support COVID-19 vaccine uptake through the use of community health workers and to build resilience in communities. La Clínica serves as one of our key partners deploying Promotoras de Salud for vaccine outreach on our HRSA project. And another project that arose during COVID was that we were asked to support the emergency response at one of our health departments. And this is where Chaya and India work. This health department recognized that addressing COVID would take more than just contact tracing. An emergency response requires trust building and supporting community members to address their social needs. So they asked us to hire a cadre of community health workers to support with the COVID response. So I'll turn it to Chaya to tell us a little bit about that project.
Buenas tardes, voy a hablar en español. Espero que esté bien para todos, ¿sí? Yo me llamo Chaya Ortiz, mis pronombres son she, her, ella, y voy a hablar sobre el papel de los promotores de salud en esa pandemia. Y bueno, como dijo Abby Charles, IPHI reconoció que hay necesidad de tener a los promotores de salud. ¿Y por qué? Bueno, primero porque en inglés decimos community health workers, pues venimos de las comunidades, ¿verdad? Cuando éramos empleados, 80 empleados, muchos de nosotros veníamos de México, Centroamérica, Sudamérica, Puerto Rico, y además de las comunidades hispanas, teníamos colegas de todo el mundo, También tuvimos competencia, seguimos teniendo competencia lingüística y cultural, porque cuando éramos un grupo de 80 personas, 25% de nosotros hablábamos español. Ahora somos más pequeños porque COVID no es tan fuerte como antes. Estamos trabajando en el condado de Fairfax, en el norte de Virginia, y en este condado, a partir del año 2020, más o menos 17% de la población del condado era hispano o latinx. Y desde el 2 de septiembre de este año 2022, 34% de todas las casas, todas las familias que hemos servido por 2 años se identifican como hablantes hispanos, o sea, hablantes del español. Y podemos seguir. Gracias. Entonces, ¿qué hacíamos antes de la llegada y durante la llegada y aún ahora como promotores de salud? Bueno, cuando la gente tenía que quedarse en aislamiento o cuarentena debido a enfermarse de COVID o estar en contacto con alguien con COVID, no podían salir de la casa. No queríamos que salieran de la casa porque no queríamos que más personas se infectaran, ¿no? Entonces, nosotros hablábamos con las personas, con los residentes por teléfono, hicimos una investigación de sus necesidades y podíamos y seguimos trayendo las cosas que necesitan para hacer la cuarentena o quedarse en aislamiento sin tener que salir de la casa. Por ejemplo, podemos traer mascarillas de cara, desinfectante de manos, termómetros. Mucha gente ha tenido problemas y sigue teniendo problemas con comida, por supuesto. Entonces, podemos traer comida, podemos usar tarjetas para los supermercados para comprar comida también, pero también trabajamos con grupos de la comunidad que ofrecen comida. También podemos traer productos de limpieza, sumamente importante durante una pandemia, ¿no? Y productos para los bebés y productos para la regla. En algún momento ahora no tenemos este programa, pero si alguien estaba en un lugar muy lleno de personas y no podía eficazmente guardar aislamiento ni cuarentena, pudimos hacer arreglos para que pudieran quedarse en ese tiempo en un lugar separado de su familia, ¿sí? También podemos ayudar con las pruebas de COVID para la gente que no puede conducir a los centros donde hacen las pruebas, ¿no? Y además intentamos conectar a nuestros residentes con otros programas en el condado y otros programas comunitarios para ayudar con sus problemas, con los problemas que tenían o que siguen teniendo. Y sobre todo, seguimos tratando hacer o crear conexiones humanas durante esos tiempos, esos periodos de mucho miedo y de preocupación. Me acuerdo que una de mis colegas habló por como 30 minutos con un cliente porque dijo que no había hablado con nadie en 5 días y necesitaba esa conexión humana, ¿no? Y por supuesto, siempre intentamos trabajar por un filtro de equidad y compasión. Y podemos seguir. Y en esta diapositiva puede ver 2 fotos. La foto de la izquierda es nuestro grupo trabajando con un grupo comunitario que se llama Rosas Blancas. Es un grupo de la comunidad, de verdad. Mujeres que, bueno, principalmente mujeres, pero también hay algunos hombres, pero de una zona en Alexandria, en el condado de Fairfax. Lo que hicimos es que trabajamos con una finca en la área para obtener comida. Ese grupo, Rosas Blancas, encontraron a la gente que necesitaba la comida y trabajamos juntos. En el otro lado, tiene una foto de casi todo el equipo. Siempre es imposible recoger a toda la gente a la misma vez para sacar una foto, ¿no? Pero también quiero reconocer que mis colegas y yo, lo digo de mucho orgullo, pero también de humildad, que recibimos un premio dorado de innovación de la comité o de la organización que se llama NACCHO, no para confundirse con Nacho, ¿no? NACCHO, National Association of County and City Health Officials. Ese premio reconoce departamentos de salud locales en cuanto desarrollen programas innovadoras para emparejar o para llegar a cumplir con las necesidades de su comunidad durante la pandemia. Y cuando nuestro director del Departamento de Salud fue a Atlanta para recibir el premio, hizo un video y en el video hubo una señora muy querida, una de mis clientes, que habló de la diferencia de los promovedores de salud, la diferencia que hicieron en su vida. Y ella dijo, fueron momentos muy difíciles, pero gracias a la ayuda, nosotras de una u otra manera pudimos, a pesar de la angustia y el dolor que teníamos en esos momentos, había una luz en el camino para poder decirnos que seguir luchando. Esta ayuda fue una bendición. Y con esto cierro mi parte de la presentación y gracias por dejarme presentar.
Thank you, Chaya. So I will be sharing some information about how we utilize the community health workers as vaccine navigators to promote vaccine uptake and confidence in the community. So originally, we were all a group of community health workers, and as cases started to decrease in the county, there became or arose an opportunity for a reassignment in which some folks became vaccine navigators. And so they received thorough training in which there was a focus on cultural competence as well as motivational interviewing. So once this group of community health workers was trained up to be ready to promote vaccine and encourage and connect people to COVID-19 vaccine opportunities in the community, we utilized zip code data. So what we refer to them, it was a very evidence-based decision, and they were high value target reports. And so these target reports we used to make informed outreach decisions into which neighborhoods had the highest vaccine rates in the community. And the majority of these neighborhoods were communities in which ethnic minorities, including Black and Brown people, lived. So examples of these areas would be neighborhoods in which people were uninsured, neighborhoods in which people had transportation barriers, neighborhoods with high social vulnerability indexes, again, ethnic and racial minorities, and then people with disabilities. So that was really our focus. We wanted to make sure that we were taking equity into account in going out into these communities and providing outreach. So the concept of this was to, one, either bring a vaccine equity clinic to the community, or two, connect people to COVID-19 vaccine opportunities in areas around them. So these vaccine navigators did a lot of different outreach, in which we will talk about in the next slide. All right, so the youth or the vaccine navigators, one of the most effective things that they were able to do was to have formal partnerships with these 7 organizations. And so what this looked like is an MOU, or Memorandum of Understanding, was developed. And it was just an agreement, non-binding agreement, that the vaccine navigator would work with the agency or organization, so a combination of community-based and nonprofit organizations, to provide COVID-19 vaccine information to community members and people who were clients of these organizations. So of the formal partnerships that we have, there's United Community, Edu Futuro, Lorton Community Action Center, or LCAC, Second Story, Medical Care for Children Partnership Foundation, Western Fairfax Christian Ministries, and Cornerstones. So these were our formal partnerships, but it is important to note that in addition to these, there are a lot of other agencies, organizations, shopping plazas, places of worship that also made this relationship possible. Next slide, please. So some of the vaccine navigation activities include attending community events. For example, Juneteenth, that is an event that is attended, or the Pro Bolivia event that is hosted annually. There are awareness days that people also attended. So for example, National Night Out. They participate in several back to school events, not only promoting the COVID-19 vaccine, but emphasizing the importance of other childhood immunizations that are required for children to go to school. The vaccine navigators are often found at apartment complexes and other commercial properties, such as shopping plazas, providing outreach to the community. So a lot of times it may look like a flyer distribution in which they are knocking on doors or distributing flyers at a shopping plaza. And then sometimes it may look like maintaining a table presence in a highly trafficked area, so farmers markets, or again, the lobbies at these partnerships where we have our MOUs, and just maintaining that presence and being there. And over time, as people continue to see the vaccine navigator, they start to associate them with the agency. And because the agency is already a trusted member of the community, that navigator also becomes an extension of trust, because as we have previously acknowledged in past presentations, there is a lot of misinformation out there about COVID-19, and there is a lot of mistrust in the community, and for very good reason. And then in addition to that, as I mentioned earlier, we had vaccine equity clinics. And so if there was not an opportunity for someone to go into the community and get their COVID-19 vaccine, we would ensure that we were bringing the COVID-19 vaccine to them. So we worked with the field vaccine team at the health department, as well as Safeway and Neighborhood Health, to bring COVID-19 vaccine into communities. We had vaccine events at churches, at grocery stores, shopping plazas, in mobile testing vans, as well as apartment complex like community rooms. So those are just some of the ideas. And then lastly, as Fairfax County has been setting up mobile testing sites, the vaccine navigators have begun doing outreach at these mobile testing sites. So they are very strategically located, again, in communities in which there are high rates of, or historically have have had high rates of COVID-19 vaccine, but then also have barriers to accessing testing. For example, there are some testing sites in their community. However, those testing sites are $100 to access if you are uninsured. So the part of this is the vaccine navigators going to these testing sites and engaging with people and reminding them, you know, hey, it may be time for you to get your booster. While we're here, let's go ahead and connect you to a booster opportunity. Next slide, please. So I do want to take a moment to share an awesome success story. So Mega Mart is a grocery store in Alexandria, or there are several locations, but this one specifically is in Alexandria. And Mega Mart coins themselves as the go-to grocery store of the Hispanic community. And so Richmond Highway in this area in particular, again, this is an area with a high disease rate at one point in time, and also an area that ethnic and racial minorities lived and congregated. And so the idea, again, was to bring a vaccine site to the community in a place in which community members highly frequented. And so the store manager of Mega Mart was just completely on board and was all for this partnership. So over the course of a few months, there were 4 COVID-19 vaccine clinics held at Mega Mart. There was a lot of outreach being done, even in the ice and snow, like just in the dead of winter, a lot of outreach being done to support this COVID-19 vaccine clinic. And ultimately, the efforts paid off and 100 community members were vaccinated over those 4 COVID-19 vaccine clinics. So that was a major accomplishment and could not and would not have happened without the support of Mega Mart. And just to wrap up, I would like to share that in July of 2021, when vaccine navigation began, only people 12 years of age and older were eligible for vaccination. So around that time, 68% of Hispanic residents in Fairfax County were vaccinated. Now, as of August 31, 2022, 96.1% of people 12 years and older are vaccinated in Fairfax County who are Hispanic. So I just think that is, I mean, I know it takes a village, it takes all of us, but I think the vaccine navigators, I would like to think, had a large role in that vaccine increase and uptake. Thank you, and I'll hand it back over to Abby.
Thanks so much, India. And I'll ask whoever's advancing these slides, if you could move 3 slides down. So just because of time. But, you know, just some of the things, even though we know that community health workers and promotoras de salud work so well, if you could just move 1 more slide, we've seen that there are still persistent challenges. Ooh, it didn't come out well. There's challenges in awareness and understanding of the role of community health workers and promotoras de salud. There's challenges with integration of community health workers into clinical teams. There's still sometimes a little tension between the professionalization of community health workers that we're seeing with certification and training of community health workers versus community health workers who are just from the community and just have true community roots. So there's still some tension there. And we have a significant barrier with accessing sustainable funding for community health workers and promotora positions. So when grants end, promotoras are usually the first role to go away. And we want to figure out, how do we sustain these community health workers? So how do we integrate community health workers at a larger scale? If we move forward 2 slides, here are our last set of points. We need to increase awareness of the role of community health workers and the value of community health workers in our communities, in the health system, and in social service systems. And we have to implement our programs for success. So we must hire promotoras and community health workers who are truly those trusted members of communities, not just people who have degrees in health or health education. They have to be trusted members of communities. We should provide CHW training, not just on a specific topic. So not just on COVID-19, but on all the core competencies, so that regardless of health issue, community health workers could work with our community members to connect them to the services that they need. We have to ensure sustainable payment for CHW roles. And to do that, that's going to take advocacy and policies to be implemented that support community health worker workforce development. And we must continue to show our community health worker value through well-designed research, program evaluation, and reporting. Everyone who needs a community health worker should have access to a community health worker. And in order to do that, we're really going to need to have the funding to support. So I hope you all will join us as we continue to advocate for more policies and financing for community health workers. So that's the end of our presentation. Thanks a lot for listening.
Thank you so much, Abby, India, and Chaya. Thank you so much for the really thoughtful and inspiring presentation of how to integrate promotores de salud, community health workers at a large scale. And now we have the dialogue part of our Diálogos para la Acción. We will have 3 breakout rooms. 2 groups will be facilitated in Spanish, and those who selected English will be discussing one guiding question in English. We will be discussing or summarizing at an individual, community, and policy level some of the actions that we can take from everything that we've learned today. So Ricardo, are we ready to split into groups?
Yep, we're ready. Dolores, hola. ¿Sí me escuchas? Bueno, Dolores, te voy a poner en un breakout room en español, si está bien. Un momento y ahorita te agrego. Dolores, ¿sí me escuchas?
And I didn't know how to do, but I'm now. So what we try to do with the diálogos is you guys on the audience, but you also was speaking, you just spoke, right? I mean, you didn't have any interaction. So instead of Q&A, what we like to do with those breakout sessions is now we dialogue a little bit here. And we dialogue and report back on the big session. So in order to dialogue, what we're going to do is answering kind of a it's one question.
Hola, Chandra. Disculpa, Sandra.
Hola, es Candra.
Oh, Candra, disculpa. 2 veces, disculpa. Te puse en un breakout room, pero obviamente no se requiere ahí la interpretación. Entonces, si quieres esperar de aquí hasta... Son 20 minutos hasta el fin del breakout room.
Ok, sí. Y me puedes poner en la cabina porque no sé lo que hice, pero salí del Zoom y tenía que ingresar de nuevo.
Ah, ok. Entonces te pongo de nuevo en el breakout room.
No, en la cabina de interpretación.
Oh, de interpretación. Ok. Entonces, Ah, sí, ahí aparece. Ok, Candra, inglés, español. Listo, creo que ya está.
We can bring to the big group some ideas that was not said already. So the idea now is like you that was listening, or you was listening another presentation that was not yours. What else we can add to this set of ideas that we people share with us so far? Who wants to speak?
I'll speak up, and I'll admit that I was like, oh, these are really good ideas. We should be doing these things. So I didn't have anything to add. I took a ton of screenshots so that I can share this with my team, because these are things that I'm like, why weren't we doing these things? It's kind of like, wow, some of these things are simple, maybe not easy to implement, but simple. And so, no, I don't have anything to add, because I was just so like, oh yeah, we should be doing all of those things.
Yeah, and you know, so even though I work at IPHI, because I'm not part of the Fairfax team, I'm learning a lot about what they were doing too. So like the work that they did with that grocery store, that I think to achieve, you know, through 4 vaccination events, 100 people vaccinated is really good, but like we should be reaching out, even though they're not a community-based organization. There are so many resources that I think we forget to utilize as we are building trust, or, you know, trying to get people vaccinated, not just for COVID, but for, you know, now it's flu season, and now there's the Omicron vaccine. So really thinking about how could we utilize like corner stores and other trusted entities to get more people vaccinated.
One thing that comes to me is like, I think we saw so many MYUs set up with organizations. And I think because of COVID, this was so much faster than before. I don't know, in your experience, I think could be also with Mary Health. It was so easy to people answer your request to do something together that I keep thinking, how could we maintain that, right? Because I think one problem that I have to serve the Latinx community is the fragmentation sometimes, right? There's a lot of parallel things going on and things happening at the same time, and we end up not really leveraging resource because, or we're competing for funds, or we are competing for the partnerships. So I keep thinking that how could we in some ways keep that? I think Michelle said that a little bit when on her presentation, the momentum, like how can we keep what we learned because of COVID, because of the kind of that feeling of emergency, to keep doing this? Like if we could really not miss the lessons learned and how to quickly partner with people and do incorporation instead of in opposition to each other, right? Especially because we still have this incredibly bad finance system that's grant-based. I think, Abby, you said that at the end, like how damaging is that to a long-term financing a system that every time that a grant ends, then ends all your infrastructure there. But also the competition for dollars also fragment us, right? Because it's hard sometimes to, so I keep thinking that one thing to leverage would really having RFAs or funding that really tells the partnership should be true, right? should be a serious partnership, not just like IMIU exchanged it without really history of partnering, because then would be a way for us to keep the partners that we made, right? So that's one idea that if you all think that we should share, like how to make sure partnerships keep being valued and into the financing, right? Instead of us competing with each other, we go together because we're working together. And partnerships, like for example, the set of people that you guys did in Fairfax, like we did similar things in Prince George because of the need, right, to where we were.
Yeah.
Other ideas?
think what you mentioned about keeping the momentum going. And I know that as, you know, it seems like we are moving away from COVID and things are wrapping up. This very event and this dialogue that we are having, I think is a way to keep up the momentum. And so sure, maybe this is like the first time that we are having the conversation pertaining to COVID and how we decreased barriers and increased vaccine uptake, but maybe we can have this again and encourage everyone on this call to invite 1 or 2 people to it, because there is strength in numbers. And like you said, you know, instead of competing for dollars, why not join forces? So I really think a good way to keep up the momentum would be doing something like this with the expectation or ask that, you know, next time we all bring a friend.
Other ideas, comments?
One of the things is, I mean, I'm new to this, so a couple of the ideas that like jumped out at me, you know, were one, like the Brigada, and they had all those social media messages, and it seems like there's a limited, you know, like audience there. So is there a way to like for the other community organizations to like get some of those messages that already work and get them out on like all the other channels, like so that like there's more education to more people, like instead of just having it be in their network, like how can that get to a broader audience? Because even, I mean, something's going to come after COVID, or how many communities really aren't vaccinated, you know, for even just the basic vaccines, like how to just sort of build that confidence up and see a community organization as also a health promoting organization. And then the other thing that and I was not fully like engaged, but the organization that got the NACCHO award, the county health officials, like those are like, our counties have resources, you know, so is there a way of duplicating what happened there in other counties and organizations and using the NACCHO staff to like, you know, like use their resources to help them promote community organizations, like doing this work and saying, hey, you guys should do this too in all these other counties, because that's how they're networked. I don't know, there's just 2 things that popped out at me that resource, especially NACCHO, and they have resources. So how do our community organizations pull from government resources in a informal way, since they're a nonprofit themselves?
Yeah, I think this is remind me what India said about promoting information, right? Or when you said to have more events like this in Campiana, how can we have more sharing more information about what is success, right? And what is a model that really works, and don't be just like among us knowing it, but to make also more people knowing. So we need one of you to report this back on the when we're back. So we have a volunteer, cannot be me because I'm facilitating. The report is very informal. You're not going to be, but we need a representative of this small discussion group. Do we have a volunteer? We don't have a volunteer? We can summarize what we discussed so far, so we don't have to remember. But it would be great to see voices that was not there before to participate.
It seems like maybe if we summarize for Suyana, somebody might jump in and volunteer.
Yeah. So I think what we said so far, let's try to recap a little bit. I think I said something about not losing the momentum and kind of repeating the partnership mode that we got into, right? So I think this was my contribution. Like, how can we keep promoting partnerships and keep finding a way to have partners the way that we did during COVID, and how we can finance this way, right? So.
Yeah, and I said that, you know, oftentimes when we think about partners, we only think about community-based organizations, but through the presentation, recognizing that, there are so many other resources, corner stores, grocery stores, and so many more that are, really trusted and utilized in the Latinx community that we should be leveraging as well.
Brenda, can you summarize your? So who is taking notes? I think Darla, are you taking notes? We have a representative to our group.
I think Darla always takes.
I know, I was afraid that she was doing, still worked, right? Because at this point we're like participating here, but everyone is multitasked. So I was not sure if she was.
I'm taking notes.
Getting ready.
Okay, we're going to summarize. I said, all right, I'm going to write it down.
Thank you, Darla, for representing us.
I also heard that one resource could be like, like NACHO or those other entities sharing these best practices with other like jurisdictions as well, to sort of amplify and see some of these best practices being done in other locations. I don't know if I captured that right.
Yeah.
Is that correct, Brenda?
Yeah, that's pretty much, yeah. Yes, very good summary.
Any other insights?
Yeah, so I'll go ahead, India.
Sorry. Keeping up the momentum by continuing to have events like this, but then expanding the invitation with the ask that everyone will bring a friend or invite another organization.
And I also wanted to mention some thoughts around something that Abby mentioned earlier about involving groups, community organizations that are not just, health organizations, but at least from my experience with my parents and trying to get them vaccinated. I feel like half the time, maybe not half the time, I don't know, have the perfect stats here, but a lot of the time when I'd hear them talking about COVID back when it was a little newer to us, it was based off of what they heard about it while they were at church, back before they'd closed down and stuff. But then afterwards going to church and through Zoom. And so for them, their religious faith is one of the things that they have the most faith in. And so I wonder, if hearing from the pastor, the priest, whatever religious leader that they listen to and hear their thoughts from, also have views that whether, they can informed views about, what the vaccine can provide, the drawbacks, just having those conversations with those leaders so that they can make their own personal choices, about what to inform their communities about. I think informing leaders like that is the first step in having that kind of network that has a broad reach and I think a very impactful reach.
Any other insights? That was not sad. I mean, that's okay too. Sometimes we're in places and people just spoke something that we agree, right? Sometimes we don't have to have a different idea. But just because that's what Believe Dialogue is, like we kind of get inspired by something that somebody said, and then we kind of, some things come to our idea, right? I mean, that's because of that. And I think this should be also part of this dialogue, not only who prepare to present, because then there is more time organizing the information, but us who are here get inspired. I just want to make a comment like that, really the importance of, I mean, we end up doing, and I can imagine you all to use a lot of what we learn with HIV prevention and outreach to do the COVID, right? We end up doing. And just remind me this, Abby, that we have like at the Columbia Heights, Mount Pleasant area, we have almost a 65 business who historically has distributed condom for us. I mean, I mean, when you're talking, I didn't connect, but now that when you said, because in the beginning of the HIV epidemic was so hard really to people to feel, I mean, the people are ashamed of of asking for condom, to go to pharmacies or to health centers. Sometimes they would come to us and go back without asking for condom, and we didn't know if they want condom, or if you offer, they would not take with them. So we made this idea of putting in beauty salons, in laundromats, and I bet you guys have that experience too. Anybody doing HIV, and there was a lesson learned, right? That I think in some ways we end up replicating now, but still a lot to be said when it's something else related to health, right? I mean, how to engage business and faith community to really understand health. And then came to me something about Michelle said about health literacy. I think there is maybe something for us to keep doing that's really explaining people how other disease happens, right? Because what happens with COVID is not different than AIDS, HIV, or diabetes, or heart disease. Is the same community, right? I mean, we are getting the same group targeted by those preventable disease, by those that can prevent it because of transmission that you know what happens, or prevented because of the environment, the chronic disease. But it's the same community has been targeted with that. Like it's the same community that having the lifespan shortened by the condition. So how to promote more understanding of health and how to prevent disease, right? I think there is much more for us to do. And I think we learned so much with HIV. Now we learn a lot with COVID that we should spread to the other health conditions and help people to really, people don't understand doctors if they're not sick.
Right.
And this is a huge problem that we have.
Yeah. And, you know, some of the data that we're seeing related to the vaccine, yes, there were, it's going to put in 8 seconds, political lines, but it was more so people who didn't have any connection with a doctor who didn't want to get a vaccine.
There was a group.
Estaba diciendo que no existen en este momento chips tan finos que puedan pasar por una aguja tan fina para meter la vacuna, ¿no? Es simplemente explicar así, ¿no? Que es demasiado grande para
Okay.
entrar, ¿no?
Entonces,
we're all back. We're all back.
Todos estábamos que nos conversábamos, pero bueno.
Estamos de regreso, we're back. Y entonces we had the chance to dialogue, and now we can dialogue even more broadly as a group. And for that we set up the 3 breakout sessions. So I'll start with group 1, and I think that was Lina.
And also back to interpretation, right, Rodrigo?
Yes, and back to interpretation if you.
So pick up your channel.
So who's from group 1? Who's presenting?
We have a beautiful
Sorry,
sunset.
I was on mute. I didn't realize. Chaya.
Lina, can you show the questions just so we know what we're talking about?
Yeah, I'm not showing.
Beautiful sunset.
Oh,
Make me
okay.
really wants to go to an island. And
I was going to say, send me there, please.
Okay.
Entonces, nuestra pregunta fue, ¿qué otros enfoques de comunicación y tipos de mensajes que resultan eficaces para llegar a los inmigrantes latinos con el fin de promover la aceptación de la vacuna? No sé si debo contestar en español o en inglés, o no importa.
No importa.
Ok.
Como
Bueno,
se dice.
hablamos de la importancia de las redes sociales, pero también yo mencioné que hay muchas páginas o aplicaciones que como soy un poquito mayor, que ni siquiera conozco, entonces yo mencioné que no es solamente cuestión de tecnología, pero también de generaciones, porque obviamente vamos a compartir en Facebook o en Twitter, pero los jóvenes tampoco usan Facebook y Twitter, usan WhatsApp y ¿qué más? Insta y TikTok y Snapchat y cosas que ni siquiera entiendo. Entonces, tenemos que enfocarnos en todos los medios de las redes sociales y hablamos mucho de las voces confiables, que la gente, y eso, en mi opinión, eso pasa con todos los grupos, no solamente entre los hispanos, pero la gente se acostumbra a reconocer información de la fuente de donde viene, que la gente se confía en tal persona y si el mensaje viene de tal persona va a creerlo en vez de, bueno, va a creerlo de todas formas, ¿no? Si es la fuente en que tiene confianza. Y ¿qué más? Hablamos, bueno, estábamos terminando de enfocarnos en el mito de que haya chips, que Bill Gates haya puesto chips en las vacunas y que todos vamos a estar controlados por eso. Entonces, Elizabeth, bueno, todos hablamos de la importancia no de hablar con jerga alta como de doctor, doctora, no somos, bueno, por lo menos los proveedores de salud, no somos profesionales médicos, así que es muy importante hablar al mismo nivel a la gente con quien estamos hablando y además dar la información tal vez en pedazos más pequeños en vez de una larga narrativa, ¿no?
Gracias, Chaya. Creo que toca seguir porque nos está acabando el tiempo.
Ok.
Mil gracias.
De nada.
Pregunta 2.
Carla nos representa.
Sí, soy representante del grupo de inglés, so I'm going to talk to you in English. We talked about several things. So one, that it's important for us to not lose the momentum once we have it. And there are several ways to do that, to keep promoting the partnerships that were established or strengthened during COVID as we were trying to put together resources and information for communities. Having events like this, but adding a feature where we say, if you're planning to attend, bring a friend along so that more individuals and more organizations get to participate in these dialogues. That we leverage resources through people who we're connected to at organizations like NACCHO or similar that can share and amplify best practices that are maybe not happening here, but in other areas of the country or even the world, so that we can have a shorter path to implementation because we already know it's something that will or might work. We also wanted to really make sure that we're thinking about the fact that our partners can be more than CBOs, that we don't have to just partner with community-based organizations, that there's a lot of power in small businesses, corner stores, salons, churches, other trusted vendors in the community where folks are living their lives, because so much about health and healthcare in the US is not how we actually live our lives, right? We don't think about going to the doctor unless we have an issue we're trying to get resolved. And while that's a shift we're trying to change in our culture, it's still the fact that people aren't thinking about a doctor unless they're sick or ill. And so where are they going every day, every week to just talk with people in their community, to spend their money, to spend their time? And let's make sure we're in those spaces.
Thank you so much, Darla. Okay, and I think Grupo 3, and I was nominated the speaker, entonces voy a hablar, lo va a hablar en español. Entonces, la pregunta que se le postuló al grupo es: ¿qué barreras deben de ser abordadas por los responsables de formular políticas para fomentar la aceptación de las vacunas en la comunidad inmigrante latina? ¿Y qué tipo de políticas públicas debemos defender para que las comunidades inmigrantes latinas confíen en las agencias de salud? El grupo mencionó la importancia de reconocer la diversidad cultural, también la diversidad en edades y acceso o aptitudes para el uso de la tecnología. Entonces, cualquier respuesta o cualquier política pública que fomente la aceptación tiene que reconocer que la comunidad inmigrante es bastante diversa y también bastante diversa en su acceso y entendimiento de la tecnología. Entonces no podemos solo depender de la tecnología, necesitamos un plan B para alcanzar y fomentar confianza para que toda la comunidad pueda beneficiarse y confiar en cualquier respuesta de salud. En términos de qué políticas públicas debemos defender, quizás no defender, pero se deben de invertir políticas que pasen legislación para que se incremente no solo los fondos financieros para que permitan que los programas de promotores sean algo permanente, sino también que inviertan en su capacitación técnica. Así podemos tener una respuesta y que los promotores puedan ser esas voces de confianza, que puedan transmitir conceptos de salud pública y puedan bajar un poco ese lenguaje que a veces confunde a la gente a un lenguaje más digerible, pero para eso necesitamos financiamiento y capacitación técnica. Entonces, creo que con eso, y también la importancia del acceso lingüístico para reconocer la diversidad de las comunidades inmigrantes que habitan. Y creo que con eso, ¿me faltó algo del grupo 3?
Qué interesante, ¿verdad? Tantas recomendaciones. Súper bueno.
Entonces, bueno, con eso le damos conclusión a este diálogo. Muchas gracias a nuestros ponentes, Elizabeth, Chaya, India, Abby, Michelle y Lina, por haber facilitado estas conversaciones con el grupo. Creo que nos vamos con lenguaje, con acciones y con nuevas amistades si no nos conocemos. Así que crecimos nuestra red profesional, pero también nos vamos un poco más inspirados a que aunque COVID nos ha dado muchas lecciones, no podemos parar ahorita. Fue algo que oía, que no podemos parar el momento, no podemos parar lo que hemos aprendido, porque nuevos riesgos de salud van a aparecer y creo que lo que aprendimos con COVID no se puede perder, tiene que ser una lección que perdure. Entonces, mil gracias a las intérpretes, Sandra y Kendra, muchas gracias por su paciencia y por su trabajo de interpretación y disfruten este jueves por la noche y vamos a pasar el resumen de este diálogo y también un poco de lo que se discutió ahorita a futuro. Entonces, mil gracias.
Y
Buenas
compartimos
noches.
también con ustedes nuestros needs assessment, ¿verdad?
Correcto.
Que Lina compartió un poco para ustedes miren con más cuidado. Gracias
Exacto.
a todos por estar
Gracias por aceptar la invitación.
Chao.
Chao,
Gracias.
adiós.
Adiós.
Bye, everyone.
Oh.
Es tan lindo.